Great. Well, nice to meet you all. So I'm the surgeon in SickKids Toronto, and I'm presenting from very cold Canada. So we've been minus 15 to minus 20 degrees whole this month. It's quite cold. Anyway, so my talk. So I've been doing this type of talk many times in sort of wide range of audience, but essentially this is so hopefully this is helpful for you to kind of um, imagine, what is takes to be an academic surgeon in the world of congenital heart surgery. And I'm happy to answer the question either this forum, or you can email me after if you want to. So, so why do you want to be an academic congenital heart surgeon? So that is a great question. But before we talk about academic surgeon, I just want to talk a little bit about what are the essential quality to be a great congenital heart surgeon. Because certainly you want to be a great surgeon before before the academic surgeon. Certainly, you want to develop effective surgical skills so that you can operate in complex congenital heart abnormalities effectively with a good outcome. You also want to have an innovative mindset to advance this field. Obviously, this surgical field in particular, this field has been advanced by great innovations. But academic mind is important to advance the research and also subsequently the entire field. And eventually, obviously, after training, you want to be a great leader, team player, and communicator among this team and then among this, community. And then also you want to be a great teacher and an educator. So those are the qualities to be a great congenital heart surgeon. But I just, in this talk, we're going to talk about this innovative mindset, how that's going to impact on the whole field, how we're going to impact on your progress, and, what this means to have academic mindset in your career. So this is just to show the idea of academic surgeons. So to have academic mind, certainly deepen your understanding of specific lesions, specific cardiac conditions, specific surgical procedures. If there's unsolved problem, by having this, academic mind, research, innovation, it will help elucidate the mechanism of the condition and therefore potentially find the solution. And then also this is the kind of platform to test the new hypothesis that if you have a great ideas. So this, research innovation platform is the, I would say, only way or best way to test your great idea in your mind. And if you're successful, those platform leads to improvement in surgical decision making and also surgical performance, improvement in our understanding, therefore, teaching education, and then subsequently, this whole effort leads to advancement of the field of congenital heart surgery. So that's how I think it's academia works, and then that's how important this to be an academic congenital heart surgeon. So just give you a couple of great examples how research innovation, academic mind leads to breakthrough and innovative approach. So this is Dr. Bailey. He unfortunately passed away a few years ago, but he's and his team in Loma Linda University in the 80s. They first performed the baboon to human cardiac xenotransplantation in a neonate with a hypoplastic left heart syndrome. This won't happen obviously with substantial body of evidence in the basic science and also translational animal research uh, to make sure this concept works, particularly in the field of immunosuppressant. And they did it successfully. That the patient unfortunately passed away 20 days later. But what they did subsequently is that they pioneered this cardiac transplantation as a true therapeutic platform for the patient with hypoplastic left heart syndrome in the 80s, where node procedure was just starting and the mortality was um, um, unacceptably high with those operations. So they achieved in the first 80 something patient transplant 5-year survival of 81%, which is unheard of, and uh, is such a great innovation, leads to like really changing the field of congenital heart surgery. The research innovation, we can't really continue talking without talking about Dr. Del Nido. He's one of the most innovative surgeon in our field. So this is one of just example of his work in 80s when he was in a research lab in University of Toronto. His concept of this, cardioplegic surgeon, he eventually went on to develop this cardioplegia. It's really revolutionized how we protect the myocardium during the open heart surgery and adopted in many, not only the pediatric, but adult cardiac center across the world. The other innovation that came out from SickKids Toronto is this ABO incompatible heart transplantation in the infant. Just that before this, so this was published in 2001. So before mid 1990s, all the transplantation happened between the ABO matched donor and then recipient. For that reason, the many patients died on a waiting list because they had to wait for a very long time. But nowadays, up until 4 or 5 years old, when ABO antigen titer is low, we actually can do it transplantation across the ABO blood type. So this is a true revolution. It didn't really happen without a body of translational works, basic science work done in many, many institutions. But the highlight is that this the research mind, innovation really translate into the clinical practice, and then they eventually change the field. So this is one of the great works done by my mentor, Dr. Glenn Van Nassel, when he was leading the program in Toronto. So this is the invasive management measurement of the oxygen delivery and oxygen consumption among the neonate who have a node procedure. So back then, the sudden death and early death after the node procedure was quite high. And so this is really to understand what happened to their physiology in a real time in a continuous manner using invasive method. So essentially, they look at first few days of primary vascular resistance, systemic vascular resistance, oxygen delivery, and oxygen consumption. And what it has showed is that, for example, the top one is it's a quantity of primary circulation, quantity of systemic circulation ratio is called QPQS, and then the oxygen delivery on the y-axis. So essentially, when you have higher quantity of blood flow going to the lungs, obviously you have lower systemic blood flow. Therefore, the oxygen delivery is impaired. So um, this has been the hypothesis, but this is sort of a real-time invasive data to show. So this mid graph is also quite important. So you see the oxygen delivery DO2 on the x-axis. So that is how much patients receive the effective blood flow per minute, and it is clearly shown that it's mainly affected by the systemic vascular resistance, and then not much so by the primary vascular resistance. So this is different type of innovation, different type of research, but it's really try to understand the clinical unsolved questions, and then by doing this very intensive prospective studies, so he was able to demonstrate what we were speculating for many years. So how to get started? Obviously, I heard that many of you are medical student, and then many of you are cardiac surgery resident, and some of your fellow kind of trying to figure out how you gonna become an academic congenital surgeon. So I'll try to give you as honest opinion as possible. So initial step towards the academic congenital surgeon, what are the key steps? Obviously, you have to recognize that this takes a lot of time and a lot of effort. In other words, this is not for everybody. If you don't want to spend hours and hours collecting patient data, or hours and hours uh, writing manuscript, so this is not your thing. So you anticipate a lot of extra time on this in your life, and a lot of time actually stolen from your daily life. But if you want to be an academic surgeon, the one is to build a habit, good habits. Same thing for the surgery. You really want to develop the habit to be the habit leading to good researcher, good surgeon. So one of the necessary habit is to generate the good research questions. So that's it's about curiosity, right? So why this happens, why this patient doesn't go well as planned, why this patient have a poor ventricular function. So those are the start. If you don't have a research question, there's nothing to be answered. And so my strong suggestion is start with a very small clinical projects like a case report, and then advance stepwise. I'll show you how I developed from my resident years to now. But you're not gonna write a New England Journal paper in the first year as a resident. I might be wrong, but majority of them don't, which is fine. And I think building up your skills, building up your confidence, building up your skill to generate a good research questions is important. And then find a good mentor, right? So I had some mentors, right? So mentor can be more than one person, and depending on where your career is, whether in a medical school, resident, fellow, or junior staff, the type of mentor can be quite different, and which is fine. And then, but the important thing is to try to find a good mentor who can actually teach you how to, conduct the research, how to think about research, and so on. And so perseverance is necessary to conduct the research. It's so easy to start, right? So let's say, your supervisor said, why don't you write this up? It sounds very easy, but to get the finish line, it's really, really hard. And then so that's what you're tested. And so my strong suggestion is that, don't give up, so that's why it's really important to start with a small project and then complete. That's going to give you confidence and then move on to more larger project. So always open to new ideas. This is quite important because research can be any field. It doesn't have to be pure surgical skill or pure surgical outcome, but there are many, many other opportunities, and then see collaborative opportunities. That's also important. So just want to talk a little bit about um, power of research publications. And, for example, if I put my name on it, all the works I've done it shows up. And then this is internationally recognized achievement. And then that's a step, footstep of your career as an academic surgeon. And it's quite visible for everybody. Let's say, you're applying for the job like 10 years later, and the employer's assistant, put your name on a PubMed, and then everything shows up. So, if you want to make an effort, I would say I would encourage to publish in a good journal that showed up on the PubMed so that everybody can see it. And obviously, everybody in this field community benefit from your research. So that's important. Obviously the presentation is as important as the publication, but unfortunately it's not visible forever, right? So that's why when you have an opportunity to present in a meeting, conferences, I will encourage to actually publish that in the journal. So I will show you this. What is
الحيوانات قوموا يلا خلصونا ننام.
this might be useful, may not be useful, but just give you an idea how I developed my career in the last 2 decades plus. So I was born and raised in Japan, so I did all the general surgery residency, adult cardiac residency, PhD in Japan, the city called Okayama. So I'm not sure you know him, but Dr. Shunji Sano is one of the established congenital heart surgeons in the field. He was my first mentor. Anyway, so I'm just showing how I developed this research skills. So it took me 2-3 years to write a first case report, which I'm going to show you in a minute. And then took me a while to get a full scientific paper. And then I really kind of ramped up my skill on the research while I'm doing the research and clinical fellowship in SickKids. And then the rest of it is my current status. So I've been a staff surgeon for 15 years, 16 years, and SickKids is like a research publishing machine. So in this 15 years, I was able to publish more than 200 publications. So this can be interesting for you. So this is so I did a 3 months rotation in the pediatrics, general pediatric surgery when I was a PGY2, and so I encountered this. It's called simple testicular cyst. This is obviously a benign tumor or cyst in an infant, and then my supervisor back then said, "Why don't you write it up?" So it took me a while to write it up, but obviously, when you do the case report, I did all the literature search back then, and then I found this 8 patient who have similar condition, less than 2 years of age. So I write it up and then published in the European Journal of Pediatric Surgery. So I think this was a good start for me because, I have no clue how I write a scientific paper, and I didn't know how to do a literature search properly. So that was, um, good opportunity. And then my supervisor was, quite good at teaching me how to write. And then this PhD thesis is about laser myocardial revascularization, which this was very popular in the 1990s, and essentially found that it's not effective to sort of chronically revascularize the impacted myocardium. So it was popular there, and then essentially died out after that. But my thesis was about this, looking at revascularization and then quantification of blood flow um, using the digital radiographic quantification. So this was interesting. And then I was quite disappointed that at the end, towards the end of my thesis, this procedure itself was largely abandoned. So I finished the PhD with very kind of a negative note, which was a bit of disappointment. But during the same time, I did a lot of work with my colleagues, Dr. Osaki. He's a staff surgeon in Wisconsin now, and Dr. Kotani is another um, um, a prominent congenital heart surgeon now in Japan. Anyway, so we did quite extensive works on DCD heart transplantation in pig, and I have one more study that I was involved. So, um, including those four study, I was involved in more than 100 um, large animal experiment using cardiopulmonary bypass. So by the time we did all of that, I was quite skilled in terms of large animal handling and getting physiological data from large animals. That was a quite positive note. And then so just give you an idea. So I did a 6 months rotation in adult cardiovascular surgery in a very local hospital. And then we encountered this middle-aged lady, or actually the 30-year-old man, who came in with a hemorrhagic shock, and then found that there's a spontaneous um, rupture of common iliac artery due to fibromuscular dysplasia. So this is obviously, I never heard of this um, disease at that time, and then I decided to investigate. So apparently it was so this was published in 2004 in Journal of Vascular Surgery, but it was very, very rare condition. And as I read, I subsequently wrote another review paper, but was quite interesting exercise. And then certainly I learned a lot from this literature search. And then so this was, during this local hospital rotation, this was my main academic work. So just give you a couple of more ideas. So during my PhD era in Okayama, Japan, the PhD students were tasked to do a transesophageal echo during the pediatric or congenital heart cases because they didn't have enough pediatric cardiologists back then. So I was doing a lot of transesophageal echo, and then I came across this idea of um, comparing intraoperative degree of residual valve regurgitation to pre-discharge echo, because sometimes it's quite discrepant, as you know. And so this was published in Annals of Thoracic Surgery, and this is purely kind of, I would say, side work apart from my PhD work. But I have to say this one of the good papers came out from my PhD era. This is another thing that we published in the Journal of Heart and Lung Transplant. So this is the first paper that I actually were able to supervise my younger colleagues as I was a research fellow back then. But again, as a PhD student, we are tasked to run the cardiopulmonary bypass in that hospital. And so we're running the cardiopulmonary bypass quite a lot, including this living donor lung transplant. And so this modified ultrafiltration is a method to rapidly filtrate or hemoconcentrate at the end of the cardiopulmonary bypass. And we found that the lung function actually improves quite a bit after this. And then so we decided to write it up and end up in a pretty good journal at the end. Um, so those, just idea that, came across during this training years. And then, just give you an idea how abundant research idea can be while you're rotating other centers. And then I came to Toronto, so Van Nastel is my mentor, and then we work quite extensively of the idea of mechanically supported bidirectional cable pulmonary shunt in a neonate and a small infant. So I did a series of animal studies, and it was quite interesting exercise, both sort of intellectually and also physically, because I had to do this um, essentially bidirectional cable pulmonary shunt in a small animal. So technically, um, I was quite happy to have a improved skill set through this animal work. And then so this clinical paper, I think this is probably the best paper that I have written as a trainee. This was published in Circulation. So this is to look at the patient with major aortic pulmonary collateral vessel. It's called MAPCA in a setting of pulmonary atresia and a ventricular septal defect. And then we look at the prediction of anatomic factors and then physiologic factors, namely intraoperative pulmonary flow study. So I think by this time I was quite familiar with how I conduct the research, how to collect the data, how to write out the paper in very efficient manner. So always leading up to this type of good clinical paper. And so this another paper that I presented and then published in the Journal of Thoracic Cardiovascular Surgery is the one that I still have this as one of the main clinical research themes. So we just published 20-year outcome of aortic ventricular valve repair in a single ventricle last year. But so this can be done, but I just want to emphasize that I cannot do this as a resident. So it was not impossible, let's say, while I'm doing a PhD, just a level of your research question, level of your skill in terms of research methodology analysis, that wasn't possible. I think that speaks to this, benefit of stepwise approach from, small project to relatively um, um, large project. And then, this is only, 57 patient, but we look at the 400 patient. But let's say, if you want to do more large scale studies that involves, hundreds of patients or even thousands of patients, you can imagine you need a, higher skill set um, to conduct such research. So right now, I'm focusing on this. So Dr. Mansoor Hussain is a cardiology scientist at the Congenital Hospital, and we're looking at the GLP-1 peptide on a cardioprotective effect. So we have this large model study looking at the effect of long cross-clamp time on myocardial metabolism, and we have great PhD student Robert Rouse generating this very interesting metabolic shift based on the length of aortic cross-clamp time and cardioplegic arrest time. And then it's more to come, but it's becoming quite interesting in terms of metabolic shift and then potential modification by the agent such as GLP-1. Also focus on this pediatric ex vivo heart perfusion for DCD donation. And so right now, Dr. Deng, she's a cardiac surgery resident in the University of Toronto, is conducting large animal study in a juvenile pig. And so we have done more than 100 animal model on a DCD ex vivo. And then we also elucidated the optimal perfusion strategy for the pediatric specific ex vivo. So those are the things that I've been focusing in recent years. So just to give you a couple of examples what our division's doing. Dr. Hala is one of our senior surgeons. He's looking at stem cell, the engraftment in the Promyati banding model. With a collaboration of scientists at the University of Toronto. So Dr. Hara and then also Dr. Mike Seed is conducting this large study to looking at it's called the artificial placenta. So this was originally introduced by the Children's Hospital Philadelphia group, but the SickKids team is one of the leading research group to really try to make this to the clinical practice. And Dr. Hara also works on this something called ultra-fast ultrasound that's have a much higher visuality and accuracy on a blood flow. And then he have this rodent model of cerebral blood flow measurement in ECMO type setting. So Dr. Coles, he has been a pioneer of this translational research in the field of congenital heart surgery in the last, I would say, 40 years. So right now he's focusing on this Fontan-associated liver disease. In particular, he's looking at this cellular senescence as a biomarker and also a potential therapeutic target in this, congested liver in a setting of fading Fontan circulation. So Dr. Vandalan is, one of my partners. She's doing both clinical multi-center registry type study and also translational studies. So she's running this North American pulmonary stenosis network. So that itself is a full-time job, but she also having this kind of a subset of patients who have genetic blood samples to analyze, to look at the mechanistic approach to the pulmonary vein stenosis. She also collaborated with mechanical engineering to look at this flow dynamics and so on. So it's a lot of things you can potentially do. And as I said in the beginning, you want to be really open-minded to that because you never know which platform actually leads to the breakthroughs. For example, it can be, engineering pathway, genetic pathway, or translational preclinical works like I'm doing. So just finish off, I do want to emphasize the importance of mentorship. So I have three mentors, and then each of them play a really important role in my career in a very different way. So Dr. Shunji Sano was my first mentor. He's a career mentor. So he's the reason why I choose to be a congenital heart surgeon. And then when I came to Toronto, uh, Glenn became my career mentor, also life mentor, and then surgical mentor. So, um, and um, and then when I started this job as a staff surgeon, Dr. Richard Weisel, he's the well-known cardiac surgery researcher in the adult world, but he stepped in as a research mentor, and that was like absolutely great help. To how to write a grant proposal, how to get research funding, and then so on. So what I'm trying to say is that you do need a mentor. You do need a really good mentor, and then it can be more than one mentor. And depending on where you're in your career, you can have different mentors. So just finish off pursuit of becoming an academic congenital heart surgeon. Obviously, you should be curious because that leads to have new ideas. But pay attention to unsolved or suboptimal clinical problems that you can try to answer. And then build a habit. You do need a good question. Without research question, your research not gonna be any good, even though you have multiple publications. Um, publication without good research question, it's really have a less value compared to a really good specific question that's the specific manuscript can answer. And I would say start small, and then advance stepwise, and then research mentor absolutely necessary and then very important. And perseverance is really, really important, right? So I've seen many fellows, both research fellows and then clinical fellows coming through SickKids, University of Toronto. I would say majority of them have a research plan, research project when they started. But to have a really good publication, to have a good presentation at the end, it's actually quite rare. It's actually, a good less than half of them. So don't give up. And then again, this is to have a good habit, um, the good habit to complete, right? So it's hard to complete. You're hard to finish, but to be a good researcher, you have to do it. So this is a great quote. So curiosity is the engine of innovation, transforming questioning into progress. I think that's so true. That is really true. And curiosity first, having the being curious is fun, right? So that's how you start the research. But some great ideas actually transform our field. So then this, the final slide I'm going to show, this is my favorite quote by Michelangelo, genius is eternal patience. So I read a little bit about him, and this is famous drawing he did it in the Vatican, but apparently it took him 7 years to do it. and then he was drawing on the ceiling, and then eventually he broke his back. But I think the patients is eventually leads to great success in this. To that, so that's my for last slide, and I'm happy to answer any question. Hopefully, this is helpful for you.
Thanks so much, Dr. Honjo, for such an insightful and thought-provoking talk. We've just got a couple of questions, if that's okay. Um,
Yeah, so one of the first questions, I guess this one came from myself. So one of my mentors actually recently said the new generation of surgeons, a lot of them think it's all about the cutting and sewing, and they don't see the rest of the career. I guess, how do you think we can work on as a specialty to improve the understanding and promote other aspects, such as the academics, some of the basic science work, morphology, some of the other research simulation? How can we promote the more holistic aspects of the specialty?
Yeah, so obviously, I think having open mind is really important, and because surgeon is not just cutting and sewing, right? The other aspect is that we, including myself, we really have to keep training your brain, your mind, because more than half of things we do is decision making, right? So we'll look at the patient, think about strategy. This execution by doing the surgery is just a very small part of it. It's obviously crucially important, but if your decision making is wrong, even you have a perfect surgery, patient die, right? Yeah, just think like broadly what do you want to be, and there's certainly if you have questions, right? Why this is you wanna dig deeper, and yeah, so I would say the academic centers like SickKids, not just cardiac surgery, but all of us in the heart center have like really good research mind, and having those colleagues, having your friend, like friend, and then finding a good mentor who have, really good research mind. So those are important aspects.
Amazing. Thank you so much. We have a question from Dr. Adrian Crucian. He has his hand up.
Hello. Can you hear me?
Yeah.
Yes.
Oh, perfect. Thank you, Dr. Honjo. Wonderful presentation. I just wanted to pick your brains on a few things because we are on a cusp of a very important change with the AI in terms of research. AI can take on a lot of the skills that were required for a surgeon in the past. And how do you see the use of this tool that many of us have not been trained how to use this? Second is, I think an academic surgeon requires an academic center, as you said. Without that, I mean, you presented your research done at the SickKids. You would agree that being in a different, smaller center without an academic backup would have been much more difficult, whereas you can develop your clinical surgical skills in many other centers. And lastly, some of the greatest examples of good research come from surgeons who are not great technically or who gave up their surgery. Let's remember Blackstone in North America. He's been able to produce a center that very few can match. In the UK now, there are dedicated academic surgeons who don't operate, but they understand the surgery. We have studies like SVR who are comparing two very different surgical methods, yet producing similar outcomes. And a lot from the research that you showed is not about the surgical methods. So thank you very much for the presentation. I just want our colleagues not to be scared that if they are not good with their hands, they cannot do excellent, or if they are not good teachers, they can be excellent researchers. Thank you.
Yeah, all great comments. So in terms of AI, I think there's a couple of really interesting observations. The first of all, there are, I mean, AI-driven research can transform, our understanding. For example, what we are trying to do in SickKids is that we'll let the AI read the echo images, like echo images itself, not the echo report. So images itself, so they analyze and we'll let them try to predict what's going to happen to those patients after the surgery. So we're trying to do that in left ventricular outer tract obstruction cases, and then also complete the ABST cohort. So those are really intriguing, methodology. Now, the other aspect is, I don't know what's going to happen to that, but I know many of high school students, universities, and they're really using the AI to do the homework or writing. And then I know it's gonna give you like amazing writing, but it's not your word, it's not your brain that's the writing those sentences. So for that part, like thinking part, if you rely on AI too much, I think we get screwed in a really fundamental way. So just those two very separate things that came to mind. And then the second comment is also valid, which is so you mentioned in line that if you're not in big academic centers, you may not be able to do studies. That's yes and no, but there's many ways to do great research, even though you're in the small centers. So, for example, many of my colleagues who had training SickKids, they practice in a very small centers in the States, but they participate in a multi-center studies like CHSS, data or other registry type data, and they contribute greatly to the science. And multi-center studies, you actually don't need to be in a large center, but you can still actively participate and do the great science. The other things, something like meta-analysis, which is another great way to contribute, or the time consuming. You may be better off if you're not super busy clinically, but your brain is there, and you can use your knowledge to apply to this meta-analysis type thing. So for example, the meta-analysis, you actually don't need to be in the hospital, by the way. If you have a good research question and then the methodology, you can do it. And I think there's many ways to do that, even though you are in a high volume academic center. Now the last question, I do work with Dr. Blackstone quite a lot. I mean, he's like a genius. I mean, he was originally a cardiac surgeon, but I think he's one of the best, surgical mathematician slash, scientist. So I think eventually, along your career, you're gonna have to choose what type of, surgeon, what type of human you wanna be, right? So we only have 24 hours. You wanna be, technical surgeons and then not much on the research, which is fine. And if you want to do more research, that's also fine. My message will be that, at least during the training, it's really important to have a research mind, academic mind, because that's really, help you to deepen your understanding, right? And then, have a hypothesis. It's not about research itself, but it's going to help your clinical practice if you have this, the mindset to investigate, mindset to get answer, mindset to get the data and then analyze. So those are all important aspect, even as a clinician. Hopefully that's answered question.
Amazing. Thank you so much. I think there's a few more questions if that's okay with you, Dr. Honjo.
Yeah.
He said, for residents, how do you advise balancing clinical work and academic work?
Yeah, that's it's a big question to answer, and I would say, so as a resident, I try to write a paper towards the end of the day. It's always hard to juggle, between the clinical practice and science. So during your surgical training, I would say the most important thing is to be in a surgery, right? So you have to be cutting and sewing until you become a good surgeon, right? So if you have a choice, let's say in the evening, to write this, finish up this case report versus there's emergent dissection comes in, whether you can scrub in, I would definitely pick the, aortic dissection case. So having said, you actually have a lot of time, and then so this is like, every day you have to pick, right? So, so every time, you pick something, that means that, you have to sacrifice something. Let's say, you have 2 hours, either you're gonna try to write one paragraph versus you watch this movie, right? That kind of stuff. So, and then, that's the everyday choices. It's accumulate over time. And yeah, so I would say part of it is a commitment, how much you wanna do this, right? And then how much how much you wanna do that, right? So, but I would say, even for me, every day is a decision, whether I'm gonna go home and, have dinner, or I'm gonna finish up this, grants, right? Or, wake up 4 o'clock in the morning to do that, or wake up 6 o'clock. Yeah. So, yeah, but there's no question that you need strong commitment to do that. Otherwise, every day is busy. And then yeah.
Like, I guess it's the opportunity cost that you have to always forgo at some level of
Yeah. Well, I
choosing
think
between.
it has to be a notion that every day you have to make a choice,
Hmm.
right? And then choice has to be, by your priorities.
We've got
I
one
think we have a
last.
question from Dr. Kumar.
Thanks, Ayush. Thank you very much for your fantastic talk, Dr. Honjo. Very, very inspiring. I had a question about sort of what you said about the value of meta-analyses, and I completely agree with you. I think we've seen something I've personally seen in recent years is there's been an increase in lots of people sort of writing and publishing meta-analyses who perhaps, don't have much understanding or experience necessarily of the field. And of course, I understand they're the highest level of evidence, but I wonder what your take on this is in terms of people who don't really have an expert opinion or understanding of the field and how that might impact, for example, things like study inclusion, which we know is, fundamental aspect of the meta-analysis and subsequent results. So I was wondering what your sort of thoughts and take on that were.
Yeah, you're absolutely right. I mean, it's really good point that, anyone can do the meta-analysis, but if you don't have a specific questions, then this meta-analysis have much less value, right? So that's why your question has to be really specific, and if you want to do it as a resident, my strong recommendation to get the expert. It doesn't have to be in the same institution, right? You can get the expert remotely. For example, if you want to write about the Epstein's anomaly, there's a world expert you can reach out and then develop the protocol together and do the meta-analysis. That's have a much more value to the community, right? So you're absolutely right. And I have to say, any field, like expert, you feel that it's difficult to reach out, but it's not true, right? So we're very open to collaborative studies and then the multi-center studies, as long as research question is valid and then interesting. So don't be afraid to reach out and then do the study together. But it's a really good comment.
Thank you.
Thanks so much, Dr. Honjo.
I think we have one last question. They've said, thank you for your great talk and great and inspiring talk. May I ask, if I come from a center that's just starting its own pediatric cardiac surgery unit, what are your suggestions to lay a good foundation? Is it worth forming a database, etc.? How would you go about this process?
Yeah, great question. Yeah, so database is essential. Having a good database, I would say it's a mandate to have if you want to run the center effectively. That's both from your quality control, like clinical quality management, and then also the research. Because that's that is the only way to benchmark your outcome, your quality of the surgery to other centers. I also encourage you to invite local expert, national expert, just look at your program, and then also as I'm not sure your level of expertise, but if you're a young surgeon, I encourage you to visit good centers with various styles. That's really going to help you to develop your skill set, your decision making, and so on.